We're going to start today discussing the assessment of skin, hair, and nails, Chapter 14. The Chapter 14 objectives include describing the structures and function of the skin, hairs, and nails, discussing risk factors for skin cancer, methicillin-resistant Staphylococcus aureus, and some ways to reduce the patient's risk with either of these diagnoses. You are going to summarize an accurate nursing history of the skin, nails, and hair. You're going to discuss the physical assessment of skin, nails, and hair using the correct techniques of inspection and auscultation. You're going to teach the client how to perform a self-assessment of the skin, hair, and nails. You will differentiate between normal and abnormal findings of the skin, hair, and nails. And you'll describe the findings when assessing the skin, hair, and nails in the individuals across the lifespan, including the adult and the older adult. So again, with this skin system, we need to know what is the structure and function. It's very important that we know what the skin does and where it is located. So that way, if there is an issue with the skin, we understand why your patient might be experiencing some things. So our skin protects the tissue and structures underneath from physical trauma, temperature, and hydration. So our role would be to maintain the temperature, balance the fluids and electrolytes in the body. We do that by absorption and excretion of salt and water, all those kind of things. We also, your skin processes vitamin D, which is important for your body functions and for bone structures. When the skin is intact, this helps the body prevent invasion from bacteria and infection. And it also is a place where we have nerve endings that provide sensation to extremities. So the skin, hair, and nails, the structures include the epidermis, dermis, and the subcutaneous layers. You learned about these in anatomy and physiology, so it's important that you know that when you talk about full thickness injuries, things like that, those are injuries that go all the way down into the dermis and epidermis possibly. That you might see those out in the hospital setting. These are injuries and incisions that we treat and watch for signs of infection. But if you do have those things are present, then that skin integrity may be a question. So we definitely look at those things. So we know normal findings or appropriate findings of vellus hair is that fine body hair over much of the body. Terminal hair is scalp and eyebrows, puberty. Patients will grow terminal hair during puberty and keep that most of their life. As patients are aging, some of these hair will change as well. Some patients have different type of baldness as they get older, and the hair may grow differently in different places related to aging. Your nails are that hardened, keratinized epidermal cells. So if your patient has thin and thickened nails, these are abnormal findings. So when we start looking at the different types of skin abnormalities and skin cancer, we look at the different types. And here's a picture of the different types of skin cancers: melanoma, basal cell carcinoma, squamous cell carcinoma, and possibly a normal mole. So we look at these to identify if someone has these things, and we use a mnemonic that we will talk about shortly. So some of the issues that patients might experience, some skin cancer risk factors might include sun exposure, ultraviolet radiation like tanning booths, You know, 15, 20 years ago, tanning booths were very, very popular. Um, they had one on every corner. And now we realize that that's probably not the best plan. And you have patients that you will see using sunscreen. Um, it has progressed over time that, you know, evidence has shown that UV light can be dangerous and precipitate someone to cancer. So a lot of times people will wear um, those UV protected shirts when they are surfing or swimming, etc. Patients have history of medical therapies, radiation, things like that can precipitate skin cancer to those areas. If there's family history of skin cancer, there's absolutely a genetic component there. Some pigmentation irregularities, you might see that with patients. If someone is very fair and freckles easily, they don't have a lot of melanin um, in that area, and they can be very easily burned with sun. Um, and also age over time can be a risk factor for skin cancer. Other risk factors for skin cancer are possibly gender, maybe chemical exposure, HPV, non-melanoma cancer there, uh, especially cervical skin cancer. Long-term skin inflammation or injury, such as burns, um, can affect this skin, and so that can put somebody at risk. Alcohol intake and smoking definitely affect the circulation to that area. Adequate niacin in the diet, depressed immune system. As you know, cancer is a collection of abnormal cells. So when you don't have your body's natural immune system to fight off these abnormal cells, then they tend to collect. So if somebody's immune system is already depressed for other reasons, that puts the patients at risk for skin cancer. So in order to reduce skin cancer, we talk to our patients about reducing sun exposure, wearing glasses and hats, avoiding sunburns by wearing sunscreen and sun protection, um, wearing long sleeve shirts, wide brimmed hats, those places where the sun tends to burn quite a bit, the ears, the nose, the back of the neck. Those are places that we would definitely want to assess for skin cancer. We also encourage patients to have skin cancer screenings, and there's a lot of places where maybe the sun's exposed you, but you can't see all the time. So in the back and the shoulders where people frequently have sun and they just don't see it. So here's another picture of these different types of skin cancer, and we use the mnemonic A, B, C, D, E. So we anticipate that when you're assessing and observing for skin cancer, that there may be asymmetry to that mole, that the borders may be jagged and irregular, that the color may be inconsistent, and you can see in these pictures and how some of the colors are inconsistent there, that the diameter may be larger, and they may have some elevation. So you can think about those things when you're looking at moles for your patient, or even for your own family. So there are some cultural variations. A lot of times those who are very pale, freckled, red hair are more susceptible to burns and skin cancer. So now we're going to talk about MRSA. So MRSA is a methicillin-resistant Staph aureus. And this is one of those infections that can cause big problems for a patient. This patient here lost their great toe with MRSA and also with osteomyelitis, because you can see where they had to remove that entire tarsal into the top of the metatarsals there. So osteomyelitis can be very, very difficult and deteriorates that bone pretty easily. So most of these patients have to get pretty strong antibiotics and long-term antibiotic care. There are also some other pretty significant bacteria syndromes out there, the vancomycin resistance, antigen. So you will see some of those things and be on contact isolation as we try to control the spread of MRSA. So there is a hospital-acquired MRSA, and this is when the hospital healthcare providers the patient gets this in the hospital. So we assess our patients. We do nasal swabs to see if patients maybe possibly have been exposed out in the community prior to coming into the hospital, because it's a big thing when we have to take responsibility for transferring these type of bacteria between patients. So a lot of times with hospital-acquired MRSA, maybe we might identify if the patients have had an invasive medical device such as a IV access or a central catheter, or maybe they were exposed in a long-term care facility. Also with any type of surgeries and dressing changes, any exposure in that way, patients can get that. For community-acquired MRSA, people can get it through contact sports, but blood and body fluid, sharing any personal items. The suppression of the immune system definitely puts somebody at risk. Any HIV, cancer, or chemotherapy suppresses somebody's immune system. So we always want to be very careful and encourage our patients out in the world to wash their hands frequently, not share personal items, things like that, to avoid MRSA. When our patients' families come and visit in the hospital, we will also encourage them to wash hands. Do not handle the patient's blood and body fluids when they're on contact precautions, and wash their hands frequently. Of your exposure as well. So for our patients, we want to reduce the risk of transferring these things, keeping the wounds covered, clean, dry, and intact. That's what we're looking for. Nail care and nail practices are something that over the past 15 years or so have really come into play. And there is a lot of evidence that shows bacteria that will attach to inanimate objects such as artificial nails. And so these nail practices are not allowed in the hospital setting. The nurses are not allowed to have those things. So you can have clean, dry nails, no gel or artificial nails are allowed. You would be amazed when the infectious disease people will swab these artificial nails, what kind of bacteria remains on them after they've been touching patients. And so be very aware. And most hospitals will not allow artificial nails, period. And while you're in school, you will not be allowed to have artificial nails either. So another thing with antibiotics is stopping the treatment when the patient starts to feel better. You must take the full dose of antibiotics. When you don't take the full dose, that allows that bacteria to mutate into something else. So that is a cause of a lot of resistance out there with antibiotics. Again, always using universal and standard precautions, avoiding contact with body fluids, If you are going to touch somebody's body fluids, you absolutely should put gloves on and wash your hands before or after. Very important, protect yourself and protecting your patient. You're going to wipe your stethoscope between patients. You're going to be very, very careful as when you're touching blood and body fluids. As soon as you are done with that, before you touch anything else in the patient's room, you're going to take those gloves off and you're going to wash your hands, because that is just as important within that patient's room and to protect yourself and others. When we talk about collecting subjective data, some of the present health concerns your patients might experience with their skin may be rashes, lesions, bruising, swelling. You may ask them about a history of pigmentation, moles. Any changes in moles might indicate that something is happening. So we need to establish a baseline. If your patient has skin disorders like psoriasis and patches, so a lot of times those things are treated with medications, and so we're going to talk to him about that. Does this lesion or plaque change, or is this something that they have consistently? That's important when we're talking about a present health concern. So we also need to know, do they have pain to that area? Any temperature variations, any itching, tingling, or numbness. A lot of times when a patient has itching, there is a different reason for that. Maybe it's a fungal type skin infection or an allergic reaction. So these things are important as we try to help them resolve that issue. If there's any hair loss or changes, you can remember at the picture that we looked at where the hair follicles are. And a lot of times that hair loss can be related to vascular issues as well. So we need to identify when this hair loss or changes has been occurring, and that might let us know about what might be happening in that area. And we talked about earlier with the sweat glands, things like that, with the processing of bacteria in the sweat. So if somebody has body odor, we want to see maybe what is happening with that. That might indicate something is going on. In the nursing history, we want to talk about medications. Some people use specific medications for their skin. Some people, especially those that have psoriasis and other inflammatory type issues, they might use steroids. So that's important for us to know what kind of things that they have been treating their skin with. Personal health history, definitely history of childhood sunburns. We talked about how history of sunburns and fair skin precipitates somebody for skin cancer. So if somebody has issues like that, I might be more focused on doing a skin cancer screening in places where maybe they've had frequent burns. If they've had hospitalizations or surgeries, we might expect that you would have a scar or something where that surgery was. So we would always want to look and make sure those things are well healed without any erythema, swelling, or drainage. We talked about family history earlier with cancer, so this is important if somebody has a history of skin cancer, any psoriasis, anything like that, other skin issues. We would want to have that documented. So lifestyle and health practices, we talked about exposure to sun or chemicals. If your patient is frequently out in the sun, it would definitely be something that you would ask about if they wear sunscreen or sun protection to prevent skin cancer or other sunburns. So daily skincare of hair and nails. You can definitely look at somebody's hair, nails, and skin. Maybe identify some hygiene practices. So this is important to help your skin remain clean and dry. We also would want to find out if they use anything special for their skin or for their nails. You can tell a lot about somebody's nutrition by the skin, hair, and nails, obviously. So diet and exercise patterns. Are they eating appropriately? Their skin turgor? Are they hydrated? Are they exercising? Um, do they have any hair loss noted? As many of you know, stress affects your skin as well. A lot of people have some levels of acne related to stress, and so we would acknowledge any of those pustules if those were present with our uh, nursing history. And body piercings and tattoos are noted as well. As probably many of you have heard, some body piercings and tattoos can get infected. And so if somebody has a new body piercing or a new tattoo, that'd definitely be something I'd be looking at. Because a lot of times, um, when your immune system is down while you're in the hospital, bacteria will collect in those areas where maybe somebody's had a new piercing and or a new tattoo. And so we would want to monitor and make sure those things don't get infected. So our objective data for skin assessment is your observation for these skin assessments, and then we're going to palpate. So if a patient has a lesion, maybe a nodule, pustule, or or a mole, those kind of things, we're going to palpate. So we're going to palpate for warmth and uh, any tenderness, things like that. If you're palpating skin overall, you're going to use the backs of your hands, the dorsals of your hands when you're palpating face and arms and legs. But if you're looking at a specific wound or a scar, the hair and nails, you'll palpate those with your fingertips. The hospital exam is very focused on skin integrity, because your patient's at risk because most of them are not as mobile as what they're used to when they're at home. So anytime that they're lying in bed in the same position for greater than 6 hours, they are really at risk for pressure ulcers to any of those bony prominences. So we are very focused on skin integrity. If a patient's had a surgical procedure or a wound, we do a lot of assessment over those things. Especially IV sites. We look at IV sites for color, intactness, swelling or drainage, any pain for the patient. A lot of hospital settings now, instead of changing the IV sites frequently, they're leaving the IV sites in until the IV sites are no good. So who decides that the IV sites are no longer patent? Well, the nurse does, because they are not, when the fluid is infusing, maybe there's swelling to that area, or maybe the IV site is leaking. And so we're doing a lot more assessment of those IV sites for intactness and discomfort or drainage. So when we're looking at skin, we are going to assess um, the skin. So you have your patient with a gown on, and you're only going to assess different parts of the skin. You'll drape the other parts. You want the client to sit comfortably. You need to have good light so you can see what you're looking at. Be sure you're providing privacy. Make sure your door is closed, the curtain is pulled, that the temperature in the room is comfortable, because if you're exposing their skin, they may get cold. So you may need a pen light if you're assessing any bodily fluid, things like that. You might need some gloves. If you're measuring a wound or um, any type of lesion for skin cancer, you probably will want to measure that. We use the Braden scale, like we talked about in the earlier chapters, to assess risk for skin integrity. And so we assess for any frequent moisture, nutrition, mobility, all those kind of things impact somebody's risk for skin integrity. So when you're looking at the skin, you're assessing for the skin's color, actual color, pink, beige, those colors, temperature, warm, cool, cold. Maybe the moisture is dry or is moist. The texture would be smooth or rough. The skin integrity, if it's intact, that means no wounds, no lesions. You want to be alert for all different types of lesions as you evaluate the hair and nails. Um, so you're going to look at the hands and nails, and you're going to go through the rest of the body. And as you're assessing the patient, you're looking for any color inconsistencies. Your colors should be consistent through your hands and arms, face. Sometimes different parts of the body are a little bit darker depending on sun exposure. So definitely something to keep in mind as you're observing the skin. You are going to look in some of the bigger clients, you might have issues with skin folds. And those skin folds will be where the skin folds together, such as under the breast or in the groin area. A lot of times, if there is, your patients may have yeast or fungus that grows there, and we have to keep those areas clean and dry. Fungus and bacteria love to grow in warm, dark, moist places. So with those skin folds, it's a prime place for those things. When we're looking for skin integrity, you're always going to remove the socks. The heels are a very predominant place where the heels are resting on the bed consistently. And so that provides pressure on that bony prominence of the malleolus. So we have to take the socks off so you can see if there is redness or skin integrity issues. We elevate those heels off the bed, especially for our patients who are not as mobile as others. We also inspect the nails and the folds between toes. Again, warm, moist, dark places are where yeast and bacteria love to grow. So between the toes is a big thing. When you look at the thickness of the toenails and the adherence of the toenails to the nail beds, that tells a lot about somebody's nutrition. So we'll also assess those things when you're doing that. A lot of times our little older folks, they can't see their heels. So you may have to get a light and look at those yourself. So when you're inspecting, you're looking for generalized skin color coloration. There's different skin types. What we want to avoid is saying appropriate for ethnicity, because what does that mean anymore? There are all different shades of most colors, so we want to show a visual picture of what the actual color is. So be aware that you're doing that. Our facilities are asking us to note actual colors. So striae or stretch marks or scars or something when you're inspecting, you're just going to make a note of those. So if the scars are well healed, they are maybe possibly lighter in coloration than the rest of the skin, but there should not be any swelling, drainage, or warmth to those areas. So here are some different shades of skin. How would you describe these? Maybe in the top left, that would be pink. Maybe in the top right, that would be more of a light beige color. The bottom left may be more of a light brown, and the bottom right may be more of a dark brown. So think about how you would visualize those colors for your patients. So here are some pictures of some tattoos and some piercings. Interestingly enough, sometimes these patients with all these larger tattoos and piercings can't stand getting needle injections, which is very interesting sometimes. But how would you document these tattoos? How would you document these piercings? So you would first note where the location is. What is the location of these piercings? Are they free from any signs and symptoms of infection? Well, that would be important as well, right? Like we talked about earlier. And same thing for the piercings. Are the piercings free from any signs and symptoms of infection? Now, I would tell you this one that's down on the bottom right that looks like a bow, looks like it has some redness to it. Now, I don't know what it's supposed to look like. Maybe that's not abnormal, but it looks kind of red and irritated to me. So that would be something that I might be concerned about, besides the obvious that there's a bow in her back. So when we look for abnormal coloration, there's some big things that stand out that indicate some abnormal findings. So here are the main colors. Pallor is the loss of color as related to anemia, arterial insufficiency. Erythema identifies skin redness and warmth. Just a large blotch typically. Could be related to inflammation, allergic reactions, or possibly trauma. But definitely when you're talking about erythema, this is redness and warmth. So here's a picture of some of these things. Peripheral cyanosis, central cyanosis. Here's this butterfly rash that's related to lupus, this middle picture on the left. This erythema on the right that looks very swollen and shiny and red, that large swath there. And the bottom picture on the left, that would be a jaundice to those eyes there. So the skin should be intact, without redness or signs and symptoms of infection. You're expecting all pressure point areas. And for different patients, depending on how they have been laying, sometimes you might see contractions, and these people have wounds in other places, but very common in the hospital setting is sacrum, heels, and those places. We talked about inspecting folds, utilize the Braden scale. We want to prevent wounds with these patients by keeping the skin clean, dry, and intact. That requires them to have baths, and sometimes in the hospital setting, they'll do Hibiclens baths to try to prevent any bacteria on the skin. We use moisturizers because we know that dry, cracked skin does not stay intact. We need the skin to be elastic and soft. If someone is incontinent of urine or stool, we want to keep them clean and dry. So we frequently turn and reposition our patients, typically every 2 hours. But if somebody has wounds already, the biggest way that you can help with pressure ulcers is remove the pressure. So we want to turn those patients off those pressure ulcers. We want to make sure that they have nutrition and that they are getting appropriate albumin every day and protein. We know that protein is very connected to healing of wounds. Some pressure ulcer risk factors and prevention. So for some of the risk factors of pressure ulcers, it would be prolonged pressure on bony prominences, but there can be pressure from any device, anything that is depressing the skin for greater than 4 to 6 hours can leave an indention. We see that with patients who wear socks that are too tight. You see an indention in that tissue. So prolonged pressure, and especially on bony prominences, that puts patient at risk. Decreased or absent perception or sensation. The patient may not even know they have pressure happening because the pain response is different. Impaired mobility, if they're not able to move the extremity on their own. Maybe increased moisture, changes in the patient's nutrition, or friction, shearing forces can cause shearing of the skin. Fragile tissue, when somebody gets older, not a lot of subcutaneous fat, and the epidermis is very thin. So vascular incompetence puts somebody at risk because you need blood flow for healing. So if there's poor blood flow to a space, healing can be very difficult. Other vascular disorders like diabetes or disorders that impact vascular spaces. Diabetes is definitely one of them. And with weight, that can make an additional challenge as a risk factor for pressure ulcers. So what can we do about it? Well, we're going to keep the skin clean, dry, and intact. We use moisturizers to prevent the skin from being dry and cracking. We're going to make sure we don't have any urine or stool on the skin. We know that those materials have bacteria in them that can cause irritation to the skin and infection. We're going to avoiding massaging over bony prominences because we don't want to disrupt the tissue in those spaces. But we are going to turn and reposition the patient frequently, every 2 hours and every 1 hour if your patient is really sensitive. Even just small adjustments with pillows and encouraging the patient to turn can really help things. And we also utilize mattresses that are air mattress and lifting devices to change patients' position if need be. For patients who have issues with malnutrition, we will give them nutritional supplements. And you'll hear patients taking protein shakes like Ensure or things like that because we know that if patient has a low albumin or low protein, that healing is a challenge. So here's some pictures of the pressure ulcers. You can see your stage 1 to stage 2, stage 3, and then the full thickness with that bone exposed there. So your lesions, we're going to talk about those for a few moments. The primary, secondary, or vascular lesions. So your skin normally should be smooth without lesions, but there are some common lesions, maybe related to weight loss or weight gain. Stretch marks or striae can be in different places all over the body, and you would document those things. Healed scars from past surgeries. And it's interesting, if you see a scar there, you might be able to identify what type of surgery somebody has had. But if you're not aware, then you would ask or look that up in the chart and make sure that that is documented. Any freckles, moles, or birthmarks, especially moles and birthmarks, you would want to look and see, is this something that you've had? Is there any changes? So identifying changes for moles and lesions is important because it might indicate that there are some skin cancer or some other things that are happening. Other lesions, we might look at maybe local or systemic problems. And we talked about some of those inflammatory issues like psoriasis and maybe some allergic reactions, some erythema like cellulitis. Very important that we look at some of these skin lesions, pustules, vesicles, such as chicken pox, things like that may show up with those fluid-filled lesions, and we need to know where those lesions located. We might see maybe a patient who has shingles. Maybe those might be at the base of the skull or maybe on the torso. So it's important to note those things because those are definitely something that you need to identify as a precaution. Some of the primary skin lesions can include nodules or tumors. These are larger, solid, palpable masses, and they can extend deep into the dermis. The vesicles or bulla, these are serous fluid-filled, elevated lesions. The wheal is an elevated mass that has irregular borders, and we see that with urticaria. Hives, those are very itchy, but they have little vesicles there. Pustules are pus-filled vesicles. A cyst is an encapsulated, fluid-filled, semi-solid mass. So it's subcutaneous tissue into the dermis, but it's a semi-solid mass. That is the big difference. A macule or patch is like a mole, a small, flat, non-palpable skin color change. Macules are less than 1 centimeter, and a patch can be greater than 1 centimeter. A papule is an elevated palpable solid mass, and they are less than 0.5 centimeters. Plaque can be 0.5 or greater, but those have the more white, silvery scales on them, but they're palpable and solid. Now, remember that nodule and tumor is larger, closer to 1 centimeter or larger. So here are some primary skin lesions. You can see the macule, the freckles, the papule would be more warts, patches like vitiligo. You've probably seen models and other people with vitiligo out in the world. And so you would want to acknowledge if somebody has that vitiligo, you would document where those are located. It's different for different patients. So plaque and psoriasis, you can see that. Those scaly, gray scaly patches. A lot of people take medications for that, and those might change, and they are exacerbated by stress and other sickness. So you would want to know how your patient's been treating that. So vesicles, the chickenpox, we talked about those fluid-filled places there, and then pustules such as acne. And some people may see acne to the body or may see acne to the face. You would just want to document those things because they might be indicative of other situations, right? So another picture of psoriasis versus eczema. Psoriasis is that scaly, silvery patch that's immune mediated. Eczema is erythematous, which is redness and warmth. Maybe even having vesicles if there is a allergy. So secondary skin lesions are the stretch marks, the scars, the ulcers, venous stasis ulcers, and pressure ulcers. So the difference between venous stasis ulcer and pressure ulcer is that venous stasis ulcers can be in those places of venous insufficiency like the calves. The pressure ulcers are found under bony prominences where there's pressure. So that's how you differentiate between those ulcers. The fissures or the linear cracks in the skin may be related more to that dry skin or to the athlete's foot, which is fungus. So here's another abnormal finding, this acanthosis. A lot of times this might be found in somebody who has uncontrolled diabetes. Dark-skinned patients might experience this, and it's a vascular issue to that skin back there, and so that skin becomes more darkened and rough in that place. So these vascular skin lesions are definitely precipitated by aging, any circulatory problems like venous or arterial insufficiency can really precipitate some of these wounds. Diabetes affects the circulatory system. Any pregnancy or hepatic disease. We talked about jaundice and liver disease earlier and how those things are connected. So a lot of times with these vessels, the petechiae and the purpura, those are related to, the petechiae is related to bleeding tendencies, and the purpura is related to maybe macular hemorrhage. The ecchymosis, irregular macular lesions seen with trauma. Hematomas are collection of that blood, typically related to trauma. There can be some bruising, but the hematoma is a localized collection of that blood. Typically there's some large bruising there. It's not just a little bump bruise, it's a large bruise. Angioma, I have some pictures of those spider angiomas, and that can be related to liver disease and pregnancy. So when you're palpating the skin, you want your texture of the skin to be smooth and even. Dry, flaky skin is an abnormal finding and might be seen in dehydration. Thicker skin and calluses um, uh, on maybe on specific places of the skin, on your feet, on some of the calluses on the outside of your feet are very common. But thin skin, especially in the lower extremities, can be seen with arterial insufficiency or steroids. We palpate lesions for size, mobility, consistency, tenderness, any drainage. Um, uh, you would document all of those things. When you're palpating for temperature and moisture, like we talked about earlier, you're going to use the dorsal surfaces, like the backs of your hands. That skin should be warm and equal. You may have some areas that are a little more moist than others, but we want them to be clean, dry, and intact. We assess the mucous membranes for moisture, and we want your oral mucous membranes to be pink and moist without any lesions. And we will talk about that as we go forward, but we always look under the tongue and we looked in the buccal mucosa for moisture and consistent pink color. We talked about central cyanosis and looking in the oral mucosa for that. So we would look at that with a pen light and visualize with your tongue depressor. We look at mobility and turgor, and we can pinch the skin up for turgor to see if it can be easily pinched. If it's elastic, it will return back to shape. When we look at edema, we use thumbs or fingers and try to press into the tissue. If the tissue stays depressed, there's fluid that's there, and we count the seconds as it returns to its normal position. But that accumulation of fluid and edema, that is not a normal finding. So we'd always document where that is, which extremity, etc. When we're looking at the scalp and hair, we're going to inspect and palpate. We're going to inspect for general color and condition, the scalp, any parasites and lesions, as you know. Sometimes people have infections on their scalp or dry skin on their scalp or maybe even lice. So we want to inspect the distribution of scalp. There are some hair loss distributions. Maybe some patients have bald spots or thinning hair. We identified that thinning hair is also a sign of hypothyroidism. So just looking at the hair and skin can give you some indication about a possible concern for your patient. So normally you are going to assess the terminal hair on the head, but you would also look at the fine vellus hair that covers the body. We would expect some people to have that fine vellus hair on their face and neck and arms, etc. Any excessive generalized hair may occur with some other issues. Different people have different hair dispersion. Some people have hair on their back. Some people have hair on their chest, depending on gender. So you're just going to assess what is the baseline for your patient. So patchy hair loss, again, might be related to either some scalp infections, maybe some past surgeries, or even chemotherapy. It's frequent that patients with chemotherapy treatments lose a significant amount of their hair related to the medication. So we assess for any lice, any areas of ringworm. A lot of times with lice and the ringworm, the patient will experience a lot of itching. When we assess their nails, we're going to look at their cleanliness, their nail color, the shape of the nails. Are they clean? Do they have any pigmented streaks? Are they 160 degrees and adhered to the nail base? Are they thickened as if they might have fungus there? So we assess texture and consistency. We want the nails to be smooth and firm and immobile, which means they can't be lifted off the finger pads or removed easily. So some common nail disorders might be related to pitting, as seen with psoriasis. Um, some spoon-shaped nails with iron deficiency. Cyanosis, as we talked about earlier, may be related to hypoxia, as a peripheral cyanosis. Clubbing might be related to hypoxia as well, and we associate that with COPD sometimes. Again, abnormal nail findings, blue nail beds, peripheral cyanosis. Short, ragged nails may be related to some mental status disorder if somebody is biting their nails, and clubbing is chronic peripheral cyanosis and hypoxia. So when we look at the IV site, we want to make sure, again, like we talked about earlier, the skin's intact without redness, swelling, any drainage, any signs and symptoms of infection. It's very important that if there is pain or if there is a problem, we're always looking at these things. You're going to be monitoring patients who are receiving IV fluid out in the hospital. And the sooner we identify that this fluid is not going in the vein in the right place, the better we can protect our patient. Once these IVs infiltrate, that fluid can go into the surrounding tissues of the vein and can cause significant problems and phlebitis. So it's important that we identify if your patient's arm is swelling and inappropriate, that we address that quickly. So here's some pictures of some of these infiltrations, and you can see that it looks very painful, and a lot of times the patients will be bruised and can deteriorate those veins in that area. In summary, can you name the primary lesions, what they look like, and what are some diagnoses related to those? What are some common skin variations that you were able to find? Were there any older adult considerations for the hair, skin, and nails? Are you able to identify the priority risk factors for patients with skin cancer? What does the ABCDE stand for with skin cancer assessment? What are the factors in the Braden scale? And what is a high-risk score for pressure ulcers? Lastly, what are the areas of concern when assessing your pressure ulcers? You have reached the end of chapter 14. Thank you.